disease-free survival is 92, 97, and 91%. I think you can get good results by taking these tumors out through the mouth. Most of them, as you can see, also had postoperative radiation therapy because of extensive neck disease. This is a classic example of combined modality treatment that I think has the lowest morbidity for our patients. And I find that the patients actually swallow and are functioning best who have had this form of treatment.
Jan?
Well, I mean, again, the decision-making in our center is a multidisciplinary. So the moment that we think that the patient needs a combined modality approach, we use chemoradiation with or without induction chemotherapy before that. But most of the patients, once they are in that situation, will be asked to participate in trials that we have ongoing. So about what is the best type of chemoradiation, because we don't feel very confident, I must say, with what most of us experience as or accept as the standard chemoradiation with a high dose of cisplatin. Well, we had discussions before about that. Many of us don't consider that an optimal way of treating patients, also because of the late side effects that we see. So we ask the patients then to participate in a trial. But it basically means also considering the fact that when there is a better local control, that the percentage of patients that have their first relapse at distant sites is becoming increasingly significant, that we have an option to use induction chemotherapy.
Yes, in summary, I would like to mention that for the very locally advanced, the stage 4 cases, I also would usually opt for chemoradiation, or when looking at the added toxicity by all these chemoradiation schedules compared with the radiation alone, the targeted therapies. And I think as more data we gain with Bonner-like schemes, we have perhaps the option to reduce late toxicities, yes, morbidities in those patients considerably. We are on the right way, I think, in this direction. And for this intermediate group, which you just mentioned, Kian, I also think there is perhaps really a better way to go for surgery in case it's still resectable, plus post-op radiation via IMRT, where you can spare the salivary gland, and like this you have not the severe xerostomias later on, and not to go in those cases with chemoradiation where you have considerable late toxicities to be expected. And I think we have also no option in case of relapse after radiochemotherapy, because especially my brother did publish on it and others, that with a scheme of about 50-60 gray and some taxane containing chemotherapy, you have even a chance to achieve about 20% 3 years long-term local control in a relapsed situation. But in these very early cases, which we discussed in the beginning, I really would opt for surgery alone and then wait. And in case there occurs a relapse where the risk is really very, very low, you have still the option of a combined modality approach. Thank you very much. You have a...
I just wanted to add one comment that I think it was an excellent summary of a very important topic by thought leaders in the different disciplines. One discipline is not represented as speech pathology. And I think while on the radiation and medical oncology, we had a lot of level 1 and level 2 evidence, surgery side a little bit lower level of evidence to support the practice, but we had no evidence for speech pathology. I heard people in each group say we have good speech and swallowing outcomes, but I didn't see one piece of data. And not only the outcomes, but what are the interventions? You know, not a week goes by that I don't see a patient treated in the community well for oropharynx cancer with chemoradiation, with oncologic control that's G-tube dependent. And it happens at our place too, but it happens a little less because we have a very aggressive speech pathologist that get involved with swallowing rehab as soon as the therapy started. So I think some of these areas where we can get very good control, even for early tumors with radiation alone or radiation and chemo or surgery alone. Really having good measures of functional outcomes will be critical for the long term to choosing those therapies.
Yeah, thank you very much for this additional remarks. I think they are just on the right direction, as I also wanted to assume. And so I close the session. Now we are a little bit late, but I think oropharyngeal cancer deserves this. Okay, have a good coffee break.
Great.